Hello everyone, this is Dr. Muhammad Asad. I am resident in Radiation Oncology and today I will discuss PARP inhibitors. So this is the outline of my lecture. I'll discuss mechanism, why normal cells are not affected by PARP inhibitors and trials through which these drugs, PARP inhibitors, approved for malignancies, toxicity and special consideration. And most importantly, I will discuss about synthetic lethality of PARP inhibitors. So as we all know that DNA damage can occur by UV light, replication errors, ionizing radiations, cellular metabolism and chemical agents. And DNA damage can be of single stranded breaks and double stranded breaks. And we all know this that single stranded breaks are repaired by PARP, which is poly-ADP ribose polymerase, and double strand breaks are repaired by BRCA1 BRCA2 genes through homologous recombination repair pathways. So how PARPs work? PARPs are actually uh, multiple enzymes that recruits different proteins and which are critical for base excision repair, and normally PARP will recognize single strand break. After recognizing, it will bind to that site and bring about pyrylation of single stranded break through repair complexes, and ultimately it will repair DNA damage and cell will survive. So if we are having PARP inhibitor, BRCA proficient cell, so PARP will bind on PARP site, it will bring about stalling and disruption of replicating forks that will result in double stranded breaks. But as this cell is BRCA proficient cell, so it will bring about double strand break repair through homologous recombination repair pathway, and ultimately cell will survive. So this is again that summary of the PARPs are poly-ADP ribose polymerase family of enzyme. We will discuss mainly PARP 1 and 2, and they are activated when there is single stranded break. They synthesizes PARP chain, recruits protein which are critical for base excision repair, and they will bring about fork stabilization as well. PARP1 trapping on DNA is the key mechanism of PARP inhibitor cytotoxicity. Regarding homologous recombination repair, these use multiple enzymes like BRCA1, BRCA2, RAD51, PLB2, ATM and CDK12. When there is deficiency of BRCA1 or 2, we call those tumor cell as HRR deficient or HRD tumor. So in BRCA deficient HRD cells, they rely more on single stranded break repair mechanism through PARP. So PARP inhibitor in HRD cell, they pile up double stranded breaks, and as this cell is BRCA deficient, so this will result in cell death of the cell, and this is called synthetic lethality. It is a phenomena in which simultaneously loss of function of two separate DNA pathways, like we have inhibited PARP pathway, and cell is or the tumor cell is already deficient in BRCA. So synthetic lethality is PARP inhibition plus BRCA deficiency. This is the lethal combination that will bring about cell death of the tumor cell. Normal cells are not affected by PARP inhibitor cells because the cancerous or the tumor cells are homologous deficient, meaning that they have already lost BRCA wild type allele as well. But the normal tissue, they they have that allele and they can perform that function of double strand break repair. But the cancerous cell, they are homologous deficient because they do not have that pathway of repairing DNA double strand breaks. So let's discuss this synthetic lethality in a dramatic way. We have BRCA as well as PARP. Cell will survive. There is BRCA deficiency, but we have PARP. Cell will survive through single-stranded break repair mechanism, but there will be genomic instability. There is BRCA, but we have given PARP inhibitors, so cell will survive. But when we the cell is or the tumor are BRCA deficient and we have given PARP inhibitors, that will bring about cell death through synthetic lethality. So let's discuss trials through which these drugs are approved for certain malignancies. For ovarian cancer, there is a solo one trial which investigated olaparib versus placebo in a maintenance. So there was benefit of median PFS of 56 months versus 13.8 months at 5-year follow-up, and the trend is towards improved OS as well. The other trial is in OLA 1 that investigated olaparib plus bevacizumab versus bevacizumab alone. So this combination improved PFS, and also there is a trend towards OS as well. The third trial is PRIMA trial, which investigated niraparib versus olaparib, and there is also improved PFS in those who have HDR tumors. So regarding breast cancer, we have OlympiA, OlympiAD and EMBRACA trials. So in OlympiA trial, olaparib versus placebo, and the population was germline BRCA1 2 mutation with high risk HER2 negative breast cancer, as well as hormone receptor positive disease but with 4 or more positive lymph nodes or non pathological complete response or ER3 or higher. So there was benefit of invasive disease free survival at 3 years, that was 85.9 versus 77.1%, and 3-year OS was 92.0 versus 89.1%. OlympiA trial investigated olaparib versus physician choice chemo, and there was increased objective response rate of 60% versus 29%, as well as median PFS of 7 versus 4 months. And more low grade events were in olaparib arm versus more high grade events with chemo arm. The third is EMBRACA trial, which investigated talazoparib versus physician choice single agent chemotherapy, and there was also median PFS benefit of 8.6 versus 5.6 months, and but there were more grade 3 and 4 toxicity of anemia than chemo arm, but patient reported outcomes favored talazoparib. Regarding pancreatic adenocarcinoma, there is POLO study that investigated olaparib versus placebo and maintenance olaparib without disease progression on at least 6 weeks of platinum-based chemotherapy in metastatic germline BRCA mutated pancreatic benefit of cancer. So there was benefit of median PFS 7.4 versus 3.8 months. Regarding prostatic adenocarcinoma, there are multiple studies like PROFOUND study that this investigated olaparib versus second line ARPIs in metastatic castration resistant prostate cancer. Again, radiographic PFS as well as OS benefit, and Triton 2 investigated rucaparib, and they had overall response rate of 44% after taxane based chemotherapy. The other is PROPEL. These studies are combination studies. So PROPEL study abiraterone plus olaparib versus abiraterone and placebo. This was double blind phase 3 trial, and median radiography PFS was 8.2 months, which was later confirmed by central review, and it was about 11.2 months. Magnitude study. This investigated abiraterone plus niraparib versus abiraterone plus placebo, and again radiographic PFS in patient with HHR biomarkers only. Is TALAPRO 2. They investigated enzalutamide monotherapy versus talazoparib plus enzalutamide, and there was again improved median radiographic PFS. So if we conclude, olaparib is indicated in ovarian cancer as a maintenance therapy, breast cancer HER2 negative and BRCA positive, and in prostate cancer in metastatic castration resistant BRCA positive prostate cancer, and in pancreatic cancer BRCA positive metastatic. Regarding niraparib, indicated as first line and second line maintenance in ovarian cancer, rucaparib prostate indicated in ovarian and prostate cancer, and talazoparib indicated in breast cancer as well as prostate with enzalutamide. Regarding toxicity, PARP inhibitors have hematological toxicities, GI toxicities, and others. In hematological anemia, for that we monitor CBC 4 weekly for first 3 months and then monthly. Thrombocytopenia, neutropenia, and one thing is very important, that MDS and AML is rare but it occurs, and if blood counts have not recovered within 4 weeks, then we should offer bone marrow analysis and prefer blood for cytogenetics to rule out the possibility of MDS and AML. Nausea, vomiting, and fatigue and constipation is with olaparib, and pneumonitis is rare. Creatinine rise is there, but no dose modification in mild rise. Photosensitivity, cardiac toxicity is with niraparib, and for that we need heart rate monitoring as well as BP monitoring. And also PARP interact with CYP inducers and inhibitors and avoid grapefruit. Regarding dose, olaparib is given as 300 mg BD, and niraparib is given based on weight as well as platelet count. If patient's weight is less than 77 kg or platelet count is less than 150,000 per microliter, so the starting dose will be 200 milligram OD. But if patient's weight is more than 77 kg and platelet count is more than 150,000, so we will start with 300 milligram OD. Rucaparib is given as 600 milligram BD, and talazoparib is given as 1 milligram OD, and 0.5 milligram OD with enzalutamide plus GnRH analog, or patient should have bilateral orchiectomy. Last but not the least, mechanism of resistance. There is increased expression of P-glycoprotein drug efflux transporter protein, reduced expression of P53 binding protein 1, that is critical in double strand break signaling and repair, reversal mutations in BRCA1 and 2, and loss of RAVE7 expression and function, and reduced expression of PARP enzymes, and increased expression of replication forks. So the take home message is that PARP exploits synthetic lethality in BRCA deficient and HRD deficient tumors, and testing, we test for BRCA mutations as well as HRR status, and indicated based drugs are indicated based on prior therapy, renal function as well as drug toxicity profile, and we look for hematological toxicity, especially anemia and MDS AML. Regular CBC is required, and regarding resistance, there is increased expression of P-glycoprotein drug efflux transporter protein and reduced expression of P53 binding protein 1 and BRCA reversion mutations. Thank you so much, and please do follow me for more videos on my YouTube channel, Asad. Thank you.